Hello, good evening, my friends, dear colleagues. My name is Helmut Messmann, and together with Gralnek, we would like to welcome you to our webinar on Wednesday from the ESGE. Now, ESGE Days 2021 was a couple of months ago, and for those who could participate on this unfortunately virtual meeting, we have now a special webinar for the highlights of this live endoscopy meeting. As you may remember, we had 4 outstanding centers who supported us and did a great job. And now, after a couple of months, I think it's the time to look back, to see what happened to the patient, what were the results. And we have today the time to discuss in detail and answer questions with our experts. So thank you very much again to our centers. Thank you first to Siegbert Faiss in Berlin, to Tomas Hucl in Prague, in Brussels, Jacques Deviere, Marianna Arvanitakis, and at the end from Düsseldorf, Horst, Neuhaus, and Torsten, Beyna. Yeah, welcome everybody. And Ian, I think we can start, and I will give over to you.
Helmut, thank you. My name is Ian Gralnek, and I've been a part of previous Wednesday webinars of the ESGE. I think, Helmut, this is very exciting because we're introducing here tonight just the highlights from ESGE Days 2021 from the live, but we are actually, this is going to be a new type of webinar that we are going to be utilizing with live endoscopy periodically during the course of 2022. And I invite everybody continue to stay tuned because we'll have additional future live endoscopy webinars as 2022 rolls on. But with no further ado, I want to remind everybody, this is now the 4th year that ESG is offering Wednesday night webinars. These are really high quality presentations on the latest and greatest in endoscopy with world leaders in endoscopy. And it also allows you to interact after these presentations. We invite you all using the Q&A function to be able to send your comments and questions. And there will be a panel discussion after each of these centers present their cases. So I'm really looking forward to this, and why don't we get started?
Okay, let's start with Berlin with Siegbert Faiss cases. Sigi, you had a couple of cases, and I think you will present today 3 of these highlight cases, right?
Yeah, hello Helmut, hello Ian, dear colleagues. Thank you for letting me participate in this wonderful meeting, and we will show you 3 cases from Berlin. We presented it in March this year, and David, if you can start with the first slide, please.
Our first patient in the session is a 41-year-old man with a non-long Siegbert esophagus. The current gastroscopy showed a suspect lesion, 33 centimeters to the dental arch. Histologically, high-grade dysplasia could be detected. Therefore, we plan now the ESD of the lesion. Professor Faiss will conduct the investigation now.
Now you can see here the C-line with a squamous epithelium in this patient, and you see this long segment Barrett's esophagus. And here is the GI junction, and if I go back, you perhaps see some slight irregularities in this Barrett, like here. And if you look, this is a normal island of squamous epithelium. Here also a small island. And I prepared also the lesion here. You can see this lesion with slightly elevated polypoid areas and a slightly depressed area with a big island of squamous epithelium. And if I change to the conventional white light mode, you can also see this area. And going to NBI, you can see regular Barrett like here, and here you see some slight irregularities at the margin of the squamous epithelium. We found no other lesion beside this one, and if I go to the near focus and focus here, you see these slightly irregulated vessels here in the 6 o'clock position, directly in the squamous epithelium. Here is a regular normal area, and here is some irregularities of the vessel. And if I go around the lesion, you see also here some slight irregularities. And as you can also see, I go back to the conventional white light mode. I have prepared some steps here. I set some margins here with a distance of a few millimeters from this lesion. We decided to remove this lesion not by EMR, but by ESD, because with ESD we have the possibility to put out this lesion in one piece. And if there is a slight risk of carcinoma, in my opinion, it's better to remove it with ESD compared to piecemeal EMR. Yeah, Horst, out. So you see, I use a dual knife from Olympus, and the endoscope, it's an HQ 190 compared with a brand new X1 processor. And I set here some coagulation marks. This is Swift cork. So now I have the whole lesion marked, as you can see. And the next step is to make the injection. And this is the ORI scale from Boston. The advantage is that this gel is like a gel and it consists a little bit longer inside. And it stays 30 to 45 minutes. Yeah, open please. I take the needle and inject please. Yeah. Yes, okay. This is also often in patients with an early cancer, that Barrett's goes underneath the squamous epithelium. Yeah? It's possible to remove by EMR, but if there is a cancer, in my opinion, it's better to remove it en bloc and not to make it in piecemeal. Yeah? I like to make a circumferential incision. Yeah? I know that there are some colleagues performing not a circumferential incision, but I like to make a circumferential incision, yeah, like this. So, yeah, look here, it's a nice incision. You can clearly see the submucosal layer, yeah, with ORI gel, and I now continue to the other side. Yeah. Here's some squamous epithelium more. I have to increase the incision a little bit here. Now I have completely surrounded the lesion, yeah? And I now will start with dissection from here. Before I start with dissection, I can show you here some vessels, and I work with a soft coagulation, and I make the decision with soft coagulation. And the advantage of soft coagulation is that you can make coagulation of the vessels. If you stay with the knife here inside at the place, you can see we have a coagulation. And if I move the knife like this, I can dissect. Yeah? The remaining specimen is only this one. And Thierry, there was no big fibrosis here. Yeah? It goes very well with the ORI gel. We injected only once, and then we dissected everything. So we can now show you the final cutting. Only one or two more cuts here, and now it's gone. Huh? So Helmut, we will remove the specimen, and after resection of the whole specimen, I go every time inside and I check for visible bigger vessels. And if there are some bigger vessels, I will make a coagulation. Here I don't see any bigger vessels, so we can stop here and finish. And for prevention of bleeding, we suggest to give PPI intravenously during the next 2 or 3 days, and we check the patient normally the next day for bleeding sign. And he stays in hospital 2 or 3 days, and then we will discharge him. And after the pathological result, we will recheck the patient in 3 months normally. And in case if it's not an R0 resection, we can decide whether we can resect at the lateral margins again. And then we have to consider Barrett's therapy, a radiofrequency ablation of the remaining Barrett in this case. So this is our plan in such cases.
Okay, please, next slide. So the first question was our therapy correct or not correct? You saw, I showed you only small irregularities at the margins of the squamous epithelium. And here you can see some pathologic slides. If you look on the left side, you can see the submucosal layer, you can say the muscular mucosal layer, and you see the mucosal layer. And on the right side of the left picture, you see the beginning of the squamous epithelium. And if you look to the Barrett glands on the right side, they are more reddish than on the left side. And this is an indication, and on the right picture, you see some dysplastic area of the Barrett, and our pathologist confirmed focal high-grade dysplasia directly in the contact to the squamous epithelium. So my interpretation was correct, and the lesion was completed without any dysplastic areas, but within the Barrett. And as I showed you before, this was a 9-centimeter Barrett. So we have to continue a few months later. And next slide, please, or next video, please. And this you can see in July, end of July. You can see the re-epithelialization on the left side of the squamous epithelium after the ESD here on the left side, and the remaining 9-centimeter Barretts. If you switch to TXI or NNBI, you can clearly see the remaining Barrett and the big island of squamous epithelium after the ESD. And our next step, next slide, was to perform a radiofrequency ablation with a Barrett system, and we decided to do it with a balloon. And 2 weeks before, or last week, I checked the patient again, and we saw now bigger islands of squamous epithelium, but remaining areas of Barrett's. And our next step was, when next slide, next video, please, was to treat with small islands with the channel system of Barrett. So in the next step, in a few months, we will check it again, whether all of the Barretts are now treated completely. So next slide, please. What is the objective to learn? We perform nowadays 70 to 80 ESDs a year in our center. And Helmut has conducted this great German study on 1,000 ESDs in the rectum, in esophagus and stomach. And as you can see, depending on the volume of the center, starting with 20 to 50 ESDs a year or more than 50 ESDs a year, you can see that the rate of curative resection, the R0 resection rate and the en bloc resection rate increase. This is normal, but this shows that you need more than 50 ESDs a year to become good results. And next slide. Our treatment, starting with the resection, is this correct or not? Looking to our guidelines, and you can see in the statement 11, patients with visible lesions in Barrett's, like in our patients, diagnosed as dysplastic or early cancer, should be referred to a Barrett expert center, and all visible abnormalities, regardless of the degree of dysplasia, should be removed by means of endoscopic resection techniques in order to obtain optimal histopathologic station. This is the reason we performed ESD in this case. And after the endoscopic resection in statement 16, all abnormalities containing any degree of dysplasia or neoplasia, complete eradication of all remaining Barrett's epithelium should be performed, preferably with radiofrequency ablation, as we did in our case. And next, please. The results of this technique are shown in this year in GUT in a large community of Dutch study, and you can see that the rate of complete eradication of Barrett is absolutely high. Only a few patients has to be treated again during the whole the years. And next slide, please. But there are some other techniques for the eradication of Barrett, like hybrid APC, and we showed also a case. And please, the next case.
Barrett's esophagus, the following patient was diagnosed with an early Barrett carcinoma in 2020. The staging showed no evidence of metastasis, and therefore an ESD was performed with a complete resection. Here in the picture you can see a regular scar after ESD and the Barrett mucosa. I would now welcome our guest from Hamburg, Professor Rösch, who will demonstrate the procedure of hybrid APC with prior submucosal injection of the Barrett mucosa.
We are using the latest generation Zoom Pentax endoscope, and we are in the stomach, so going back. Here is the cardia folds, and I think you nicely see the transition into the Barrett's esophagus from the stomach epithelium. So if we go back, we have here some tongues, and also we see here a typical Siegbert Faiss scar, very nice one down there. If we switch to another eye scan mode, which is equivalent to other imagings, you know, this is the scar. And we also have a look at the residual tongues here in order to make sure that there is no neoplasia or no visible neoplasia, which we would have to resect. Usually this is biopsied. And here you can see sort of a regular Barrett's epithelium. We again go to eye scan 3 and can also, if we want, to apply some magnification. Everything is regular, like here as well. So we don't use a catheter, we just inject the acetic acid through the scope. I don't think there is anything suspicious here. Why APC? Well, you have a choice usually. The standard or the treatment which was most published on for ablation is radiofrequency, a lot of studies. But it's not forbidden to have alternative techniques. You know, when recently cryotherapy came out, people all of a sudden discovered how painful RFA is. So there might be a place for additional treatments. We did a multi-center prospective study where we started with, this is 6.0, which corresponds to 60 watts of the previous generation. You have to touch it with the right. Now, in the oblique position, you see it's not always that easy, but this is what you have to do first. Now it's coming, see? Okay. Of course, a good sedation is always helpful. Yeah, now it's elevating. Okay, so we are targeting this area. We will do everything. The old studies of APC are not so good, in fact. But this is a new technique. This is done much more carefully.
What is the advantage of lifting? Can you explain?
You can go a little bit deeper.
Do you use, I mean, this APC is as superficial as is usually, or do you use a different technique to make it more?
It's a little bit deeper, but due to the cushion, you don't go too deep. So this is what we do. Then we extract the probe. And then we scratch the tissue and see whether we have to do or want to do a second round. The area looks quite okay, I think, up to here. So we will do, the second round will be very superficial, but I think we have to continue working here. The surface is scratched away, and we will continue doing the same thing on the other side.
So, David, if you can show the next slide, yes. Here you can see the result after 3 months. You see on the right side the scar after the ESD, and you see only on the left side a 1 millimeter island of Barrett's esophagus. And I biopsied the distal lesion on the 2 o'clock position, and it was not a Barrett, it was inflammation. So in this case, we have a perfect result after hybrid APC of a remaining Barrett after ESD. And as Professor Rösch mentioned, next slide, please. He conducted a multi-center study of hybrid APC, and also some of our patients we included in this patient. And you can see 164 patients, and patients completed therapy were nearly 150 patients. And on the left upper downside, you can see the primary endpoint of the study was complete ablation. And we received either in ITT or in per protocol that 87 or 88% of the patients had a complete ablation of the Barrett's after 3 and 6 months control. And what about neoplastic and recurrence? Next, please. You can see freedom of recurrence. We have only 55% or 65, respectively 70% of patients with complete recurrence after 6 months control. So this technique is an alternative to radiofrequency ablation. In my opinion, it's a good option if you have only small remaining islands of Barrett's. If you have larger one, the balloon from Barrett's or the channel device from Barrett's has some advantages. But in small islands, it's okay to use the hybrid APC. And our next case was a case with a small...
Our next 46-year-old patient is known to have an FAP. Already years ago, a colectomy and an ileal pouch were made. The routine endoscopy now showed multiple func, gland polyps and a sized progressive adenoma of the papilla with low-grade dysplasia. Therefore, Professor Faiss will demonstrate the papillectomy now.
As you can see here, this is the typical behavior of patients with familiar polyposis, with multiple 1 or 2 millimeter spreaded adenomas through the duodenum. And you can also see the small adenoma at the papilla here. And because I know the patient since a few years, I check him every year for the papilla, and 2 years before, firstly, I saw a little growing of the papilla, and last year a little bit more, and I took biopsies and was a low-grade dysplasia. And this year I asked him if we check the papilla again and it's a little bit bigger, then we should perform papillectomy, because the other adenomas are still only 1 millimeter and they stay since 20 years like they are. And before you decide to do papillectomy, you have to be sure that there is no growth inside the CBD, inside the common bile duct. And for this reason, you can perform endoscopic ultrasound to look whether the CBD is a little bit enlarged in the pancreatic duct, or you can perform MRCP, and you have to check the liver enzymes as well. And all these things are completely normal. As you can see here, I put the snare at 12 o'clock position at the papilla. I open the snare and then I push the snare down. Yeah? And now Gudrun can close slowly, 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 slowly. And then I have the whole papilla inside. And then we go to suck. Perfect. So, and now I suck the specimen inside. Looks that I'm inside, that we can look inside the CBD, I think. Huh? Yeah. So now the next step is to take a guide wire, and I don't try to find the pancreatic duct with contrast. I will try to cannulate it with a guide wire. So I take a sphincterotome and show me the guide wire, yes. And the pancreatic duct has to be here on the right side. But I think we look directly in the CBD. I'm inside one duct, but I think it might be the CBD. So please X-ray, please. So Gudrun, now advance the wire slightly. Huh? Okay, in pancreatic duct, perfect. Push, 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 perfect, perfect, perfect. Okay, so I'm lucky today, okay. So we put the sphincterotome out. And I take a small 5 French prothesis. Now the prothesis come, I check it with X-ray. Zieh mich ein bisschen mehr, zieh mich ein bisschen mehr. Okay, so that's und entkoppeln. Okay. In this case, it was only a small papilla, a small adenoma. I think it's absolutely sufficient to remove like this. And we check the patient in half a year again to take biopsies. You are right if there is more, yeah? But you can see I removed the whole papilla. The fold is not the adenoma. It was only the surface of the papilla to be adenoma. But in other cases, you have to remove the fold also. But in this case, I think it's absolutely enough to make this. And you can see I removed it to the deep. You can see inside the common bile duct and inside the pancreatic duct.
So next slide, the histological result was a low-grade adenoma. And the question was, as we discussed during our last session, did I remove less or whether I have to remove more in this case? And I show you the next video, and you see the results last week, and you can see an absolutely normal papilla with a normal orifice, and the adenoma was completely removed. There was no residual adenoma. So it was a correct decision to remove only the papilla and not the whole surrounding of the papilla. So next slide, please. So was it correct what we did? Yes, ESGE recommends on block resection of ampullary adenomas up to 20 to 30 millimeters in diameter in order to achieve a complete resection. Yeah. And next slide, please. ESGE recommends also a direct snare resection, as I did, without submucosal injection. If you have some adenoma beside the papilla, you have to inject. But for the resection of the papilla, don't inject. It's easier to remove it direct with a snare. And also to bring a pancreatic stent for the prophylaxis of post-ERCP pancreatitis is mandatory. And we leave this stent for 1 week inside, and after 1 week, I remove the stent. And next, please. And also make a long-term control of these patients by control after 3, 6, and 12 months. And in this case, with familial polyposis, we also examine the patients every year. So this was our three cases from Berlin, and I'm open for discussion now. Helmut and I, please.
Thank you, Sigi, for these great cases. Thank you for
Thanks,
this
Sigi.
didactic, wonderful presentation. And thank you for also showing the corresponding guidelines. And you said, well, did I correct? Yes, you did, obviously, because the ESGE guidelines are very, I think, very popular among our community and has a lot of recommendations. Maybe we start with the first case, probably with the Barrett case. One of the main questions always is EMR or ESD. And in the guidelines, ESG guideline recommends ESD in cases where the lesion size is more than 50 millimeter, or we expect a submucosal invasive cancer, or if you have not appropriate lifting. So what was your decision in this case to go for ESD and not for EMR?
First of all, there's only, in my opinion, only one published study from a Düsseldorf group, only with 20 patients combining checking ESD versus EMR. And Thomas Hucl is doing a bigger study, a randomized study, but he has some problems to gain enough patients, as I heard from him. And in my opinion, if there is a suspicious to have high-grade dysplasia or invasive cancer, no surgeon will take his knife and cut in between the tumor. And I know that there are a lot of data showing that EMR, piecemeal EMR, even in mucosal cancer, is without any recurrency and is without any metastasis after 5 or 10 years. But I'm looking the case like a surgeon. I'm not a surgeon, I'm a gastroenterologist. But I learned from all surgeons, never cut through a malignant tumor. And if there is no suspicious of high-grade dysplasia or invasive cancer, EMR is okay. If the lesion is absolutely small, EMR is okay. But if you have a bigger lesion, I prefer ESD. But I know there is no data that I can convince you.
I have the same opinion as you, Sigi. I think lesions larger than 50 millimeter, and this was ESGE recommends, are ideal for ESD. Meanwhile, we have a couple of centers in Germany. You were one of the centers who had a high experience to do a block resection. And then you have a nice histopathology to confirm what is the appropriate diagnosis, a final diagnosis. And we did a study, and you were involved in this study where we asked experts, can you discriminate, can you differentiate between a mucosal and a submucosal cancer? And we had we had experts and we had AI, and both can do better. AI can be trained with more data, but the experts, I think they are really experts, and there is, from my opinion, they cannot do very much better, and the majority of those who do Barrett are not so experienced as this Barrett. So in my opinion, it's easy to say, if you have suspicion for submucosal cancer, go for ESD. But honestly, it's so difficult to say this is a submucosal cancer or not. So I would do the same procedure. And Ian, what would you do in this situation? Would you also go for ESD, or do you think in your country EMR is more popular because it's easier, it's faster for sure? Maybe it's cheaper. We don't know. We don't have data on the costs analysis. In contrast to the colon, we have an additive treatment with ablation technique. So we are a bit more on the safe side if we do piecemeal EMR. But for me, it gives me a better feeling if I had a Barrett lesion to take it out in one piece.
I think that here they're still in Israel. Unfortunately, there's a limited number of individuals who are doing ESD, let alone ESD the esophagus, which really is even a higher skill level than ESD in the stomach or the colon. I think that most people here would probably do EMR. I agree, though, theoretically with what you're saying in terms of suspicion of if there's submucosal invasion, ESD would be the better option over EMR. Ziggy, there's a couple of questions here from the audience I want to run by you.
Yeah.
Somebody's asking, is there any role still today for PDT in management of Barrett's, or is that just a palliative measure?
Photodynamic therapy plays no role in this.
Okay.
I would say almost no role. We have one case per year probably where we do as a rescue treatment. If all the ablation technique fails, then you can try, but I completely agree with you, Siggy. There is really almost no role, no place for PDT.
There's one other question here that says, I think they're asking about the hybrid APC. What was the wattage and the flow rate that you usually use, Ziggy?
Normally it's 60 watt.
60 watt? Yeah. And what flow rate?
I think it's 2, but we
2 liters. Yeah. Okay.
Then, well, let's discuss ablation techniques. You showed the RFA results. You showed the hybrid. At the end, we will have also a case today for those who will join. So along with cryotherapy, when will you use which technique? What is your recommendation? As so far, not so many data comparing head-to-head these techniques.
So I have no experience with cryotherapy. I have only experience with ablation, with radio frequency ablation, and with a hybrid APC. And as I mentioned before, in a large Barrett, in a circumferential Barrett, it's more easier to use the balloon system to make a complete eradication. And the hybrid APC is not so good, in my opinion, if you have a large lesion. If you have 4 or 5 centimeters Barrett, it's a little bit boring to make it with hybrid.
Yeah.
But if you have a small lesion, one centimeter, it's easy.
Agree. I think
we have time, I think, for one other quick question here from the audience. Any particular tips for how you handle post-ampulectomy bleeding?
Oh, post-ampulectomy bleeding is sometimes difficult. Sometimes you have a big arterial bleeding, and when don't use clips. Clips, in my opinion, are forbidden at the papilla after ampulectomy. My strategy is first to inject some adrenaline to localize exactly where the bleeding was, and sometimes it stops. You have a better vision. And then if you have a concrete visualization of the bleeding point, I go with the core grasper, but only 1 second. If you have a big coagulation zone at the papilla, the risk of pancreatitis increases dramatically. So be careful, never use clips, injection techniques, and be careful with coagulation.
Yeah, I completely agree. We had a prospective trial, and the bleeding rate in ampullary lesions were much higher than in duodenal adenoma. So we always have the patients kneel by mouth for 24 hours and do a control endoscopy the next day.
Yes.
Yeah.
Okay, good answer. Helmut, I'm going to turn it back over to you. I think we need to move on now to Prague.
Yeah. So thank you, Siggy.
Ziggy, thank you. Thanks,
Great
Ziggy.
cases from Berlin.
Really great.
And we move now to Prague, to Thomas. Good evening, Thomas. Hi.
Good evening.
Thank you for participating again for ESGE Days 2021, and now with the highlights from Prague. And I think you chose also some interesting cases, and let's start with your cases, please.
Thank you. Thank you for the invitation. We can start with the first case.
The next patient is 72-year-old male who had a colonoscopy for rectal bleeding. A large mixed type laterally spreading tumor was found in the ascending colon, and it is planned to be removed with the endoscopic mucosal resection.
You can see the ileocecal valve down below, and we can obviously see the huge bulky lesion here. So the first objective of this demonstration is to show you how to decide what is the best option for treatment. The first thing that I would like to know is what is the risk of submucosal invasion if cancer is present in this lesion. And I hope that everybody would agree with me that this is a LST granular type, and this is subtype mixed granular nodular. If there is a submucosal invasion in this lesion, then we can expect that this submucosal invasion will be underneath the biggest nodule, largest nodule, which is here. And importantly, this is almost in 90% unifocal. There is no region without pits or with amorphous pits 5N according to Kudo. Of course, we need to examine all parts of the lesion, but please trust me that I did before we were online, and I couldn't see any 5N pits. So it is my opinion that this lesion is amenable for endoscopic treatment because the risk of deep submucosal invasion is roughly 5%, and we can expect that this invasion is under the largest nodule. If we will remove the lesion piecemeal, then I think that we should remember that the piece of the lesion that is suspected for submucosal invasion should be removed unblocked and set separately for histopathological examination. So I have an injection now, and we will inject the lesion using Orice gel solution. So we can move on. Okay. So we changed the position on the back. I also tried to retroflex in the cecum, but it was not easily possible. So I think we did a good progress from anal side now. And we are dealing with a lesion on the oral side, as you can see here. So maybe now the time is to once again try the retroflexion. I managed to, from retroflexion, to do some submucosal injection, and then the lesion averted to my side. Like this, I was able to remove a substantial piece of the lesion here and here, but still I have something on the edge of the other side, which I will remove now. So this is my progress so far.
Okay, congratulations.
So I think this was a difficult lesion, especially for a live demonstration, and I would like to give you some follow-up. I would like to start with a question to the audience. Based on the visual characterization that we were able to see, what do you think that the histology was? Was it either tubular adenoma with low-grade dysplasia or high-grade dysplasia? Was it already cancer, or was it tuberculous adenoma with high-grade dysplasia? You can please vote now. In the meantime, I would like to tell you that there were no complications during or after the procedure. The patient was discharged the next day, and we waited to see what the histology result was. So almost half of you thought that this was a tuberculous adenoma with high-grade dysplasia. We can move now to the next slide and show you what the final histology was. So there were obviously multiple pieces available for histology examination, the largest of 25 millimeters, and this was a tubular adenoma with low-grade dysplasia only. We came back to this patient, next slide please, 6 months later and performed a colonoscopy. You can see some images here on the left-hand side, and in white light there were some little polypoid lesions at the scar, and we were unsure if this was just a hyperplastic or reactive tissue or adenoma. Even with we're unsure even when using NBI, so we resected this polypoid lesions with a snare and also with a forceps, and then treated the patient with ABC. And now we will see, please, next slide, the histology of the pieces that we obtained. And there were only secondary or reparative changes with no dysplasia in any of the pieces that we obtained. So we can move now to unless there is discussion right away for each case. I leave this up to the moderators. We can move on to the next patient.
Let's continue with the next case and then we discuss
at the end. Okay, thank you.
Well, welcome back. The next patient is 56-year-old male who had a 3-centimeter rectal polyp removed by endoscopic resection in 2014. The histology showed tubular adenoma with high-grade dysplasia. At all of his follow-up endoscopies, 6 months after the procedure, and then in 2018, 2020, there was a local residual neoplasia that was found and was managed with snare resection. The histology was tubular adenoma with low-grade dysplasia. At his latest colonoscopy, just recently, there was again a local residual neoplasia, and as it is his 4th recurrence, we scheduled this patient for full-thickness resection.
We think that the lesion is, it looks benign. It looks like, again, adenoma rather with low-grade dysplasia, nice too. And the size, we believe, is below 2 centimeters. We are a little concerned about the fibrosis that there may be, since there were so many attempts to treat it with a snare resection. Yes, we are in, so you need to be patient and push gently inside, and we should be now inside. You should also know that the visibility, of course, will be reduced. Anichko, we are standing in front of a minute. So one of we are doing markings, of course, to mark the edges of the lesion, but also they may help us to find the lesion especially if it is located far further away in the colon. So now the last part of the device is this grasper. Can we open now? So it's quite a large grasper. We'll try to grasp in the middle of the lesion. Go. So we see some of the markings turn like this. I hardly, to be honest, it's difficult to see all of them, in my opinion. Like this, please hold.
Yes,
so I want to center.
Not bad.
I want to center the lesion. I think it's not bad. You agree? So the thing now is that often when you pull too much, then you will eventually lose the lesion. So I'm going to get ready now. I think this may be enough. I'm also sucking and I'm releasing. So the important thing is that you start cutting after the release is done. Otherwise you will make an opening. We can appreciate that this was a transmural resection. I don't see any, remaining adenoma here. There's still, even if there's a little bit left within this pseudopolyp, this may fall off. And then even though your the tissue that you sent for pathology is not R0, if actually the patient may still have been treated, radically.
Do you administer any prophylactic antibiotics for this procedure?
Yes. Yes, thank you for the question. We do, and we give usually some penicillin with clavulanic acid and metronidazole IV, and we keep our patients overnight for 1 day. So I think it is, from this point of view,
yeah. Looks like an R0 resection, but we have to confirm.
It looks
by
like
the
an R0 resection.
So I think we will have again a question for the audience. If you were the one treating this patient, how would you have proceeded? So would you have gone for a full thickness resection as we did, snare resection, biopsy forceps, and coagulation forceps, or APC only? So as we wait for the answers, we can, it was in this patient, there was actually an interesting complication that happened the next day. So we see that 2/3 of the audience would have gone for the same treatment modality as we decided. Next slide, please. So the patient was, so we'll start with histology. So one piece of 25 millimeters, this was a tubular adenoma with low-grade dysplasia, and it was a R0 resection. We can see in the middle image the border between normal mucosa and adenoma. And on the left-hand side, we see an image of the muscularis propria, and this was a transmural resection. So this patient, next slide, please, complained of bleeding overnight. And so we came back and did a colonoscopy in the morning of the next day. And so there was a little bit of blood in the rectum and clots covering the pseudopolyp that we created with the over the scope clip. So we wanted to get rid of some of the clots in order to have a better idea where the exact bleeding site was, and we're able to remove most of it, and then we're able to find a few individual spots with little oozing of blood, and we treated these lesions with a coag rasper. It was a surprising complication for us. I have to admit, after treating over 50 patients in our center, this was the first time we observed a bleeding. And at the end, when after this treatment, we applied Purastat on the lesion. There was a still tiny oozing of blood in the left lower corner, and to prevent further bleeding, we applied Purastat. Next slide, please. And we came back as in the first case 6 months later, and we can see a nice scar in the white light image on the left-hand side and an NBI image on the right-hand side. That from the endoscopic view, there were no signs of residual neoplasia. And next slide, please. Histology from the scar revealed only reactive epithelial changes with no dysplasia. So we consider this case, despite the complication, to be a successful case. I think we can move to the next slide.
Next patient is a 80-year-old male who had undergone 2 years ago a laparoscopic rectosigmoid resection for colorectal cancer, which was complicated by anastomotic leak with peritonitis, for which a colostomy was carried out. A year after, he had the colostomy reversal with temporary ileostomy, and unfortunately, a rectal anastomotic stricture developed. Despite several sessions of endoscopic dilations, the stricture recurred. And as the patient is a high risk for surgery, we decided to place the lumen-opposing metal stent.
Looking at the opening of the stricture, I should say maybe closure of the stricture, it's a very tight opening that we cannulated with the catheter. I'm going to come a little closer. Can we get the X-ray image? And we will now inject contrast. So we should see a colon full of diverticula. The surgeons actually refused repeatedly to inject. So I think we can confirm that we are in the colon. Water, please. We inject a little bit of water. So we are in the colon, maybe a little more here. Inject. So I think this is a short anastomotic stricture. I don't want to lose my position. This is enough. I think now, when you see the image, you can appreciate the shortness of the stricture. Wire in, please. A little bit of water before we exchange for a wire. And we will now go with a wire. Can you see the wire? Is it positioned well? Yeah. We now will introduce a 20-10 hot axio stent. We will not. You've seen a lot of hot axio stents being placed for draining collections. This will be a different application, rather a new one.
Would it be an option also a stent rather than a LAMS in this case? Another type of stent?
Yeah, you could probably use a covered stent. I think generally using covered metal stents is associated with a high risk of migration. This is true also for LAMS. So we'll start with the first step. It's important that this, actually, since this is not locked in the working channel, this is of no use. Okay, this is what we use to enter a cavity. So this we keep locked. Open this, and we will now open the distal flange. Patrick, is it being open? Okay. Okay, so we now pull back, and we already see the dark part of the thing. So this is a short stricture. I don't know if we can have more light here. So I'm actually going to apply pressure now, which I'm doing, and I'll ask Hannah to open the other part. So try to start opening slowly. Yeah, we see the stent. Keep going.
Yeah, yeah.
See the stent, yeah. Yeah, go away, Pavel, a little bit from the endoscope. Pavel, move back. No, the other way. Away from the endoscope. Good. Go. Go.
Okay, great.
Okay, so yeah, so I think this is the way that we intended to do it.
Okay, well done.
So it seems to be the end of the presentation of the case. So we can move to the next slide. And again, we start with a question. In case you also used a LAMS, for how long would you leave a LAMS in place? Would it be for 2 weeks, somewhere between 4 to 6 weeks, for 3 months, or would you just leave it there forever in such an indication? So this was a sort of off-label indication and was discussed with Boston Scientific. And we were very excited about the indication in the case. And so about half of the audience selected 4 to 6 weeks, which is what we did. Next slide, please. So there were no complications during the procedure or after the procedure, and we came back in 6 weeks And this is the video. This is the image that we obtained when entering the endoscope. We saw a full opening of the stent. And after extracting the stent, there was a very wide opening. The anastomosis was widely dilated, and we could easily, with a standard colonoscope, enter the colon above the stricture. There were just some slight changes caused by the mucosal changes caused by the stent. So we were at this time very excited and very happy for the patient, and waited what would happen next. And we wanted to come back in some time before we this was a person very highly motivated to get rid of his stoma. So before doing a surgery again and getting rid of his stoma, we did a colonoscopy at 3 months. And unfortunately, as you can see here on this image, that the anastomosis closed completely, and there was a stricture which was pretty much the same as before. We were not sure what to do with the patient, and our idea was to maybe try again. And now coming back to the question that I asked, perhaps leaving the stent in place for a longer time. So 5 months from the original procedure, we reinserted the same stent. And can we get the next slide? Unfortunately, this time it was not without complications, and the patient, after like 4 weeks, the patient complained of bleeding, daily rectal bleeding. So we came back, and the stent was in place. There was the lumen was dilated, the stenosis was dilated. Again, we could easily pass with a colonoscope upstream. However, there were this time more severe mucosal changes, including ulcerations with bleeding. So we decided to extract the stent. And when we came back, even 1 month later, there was again a complete, as we see on the right-hand side here, this is just an image, there was again a complete closure of the anastomotic stricture. And I'd like to move to the next patient, please.
The next patient is a 42-year-old lady who's been suffering from type 1 diabetes since she was 5, with severe complications such as diabetic nephropathy and diabetic neuropathy. She's been complaining of postprandial fullness, nausea, and vomiting for the last 3 years. She was diagnosed with gastroparesis on the gastric emptying study, which was refractory to the medical treatment. The gastroscopy showed food retention in the stomach, and we also objectified the pylospasm with the impedance planimetry with the endoflip. So the patient is now scheduled for the gastric per oral endoscope myotomy with endoscopic suture.
The mucosal incision, as you can see here, we performed approximately 5 centimeters from the pylorus. Was not easy because of fibrosis. We are now finishing the tunneling, which is long enough. And now is the crucial step, and maybe the most difficult for GPOM case, to find the pyloric arc. So here's the pylorus, still a little spastic, but was much more before starting the procedure. And now we really try to find the pyloric ring, which should appear at 6 o'clock position. I switch from spray coag to more gentle endocut mode. This is the typical image you should get to start myotomy. But we had a problem to find this image. I will show you what happened. We performed the tunneling, but here I should have gone up, but I thought the pylorus is somewhere here, and you see I created the perforation of the serosa, and fortunately is not the mucosa. And then I realized that during tunneling I became below the muscle layer. And this could happen if you have severe fibrosis, and then the orientation is really difficult. We will now proceed a myotomy, please knife, because we can continue the procedure despite the perforation open. And we work like that. I think the shorter myotomy could be good, and that's all. And here we see the incision, which we are going to close by using Apollo overstitch device. So I will try to close the first stitch. I didn't close the perforation because I'm sure we will be safely closed by Apollo. And if the mucosa is safely closed, there is no need to close the perforation. Okay, it's done. And the suture is done, is complete.
Thank you. And the course of the disease was uncomplicated. The patient did well because of the perforation that you saw in the video. We did an X-ray study on the second day, and it showed, as you can see on the image in the middle, no leak, and the patient was discharged. We did a gastroscopy and clinical follow-up after 3 months. And please, can we please play the video on the right-hand side? And clinically, the patient improved. Practically was a complete remission and disappearance of the symptoms, and there was just a little bit of residual food in the stomach. However, the pylorus was relaxed and opened, and we could see, as you can see here on this video, and we did a clinical follow-up just recently, and the patient is pretty much, we can say, without any symptoms. Thank you for your attention.
Thank you, Thomas, for this great cases.
Thank you, Thomas.
I think we can discuss briefly with a couple of questions are coming in from the chat, and to the first case, there was a question, is this a case also for underwater EMR? I mean, recently we did a huge randomized study. We would exclude those type of polyps. I think underwater MRI is mainly possible for flat lesions who gets then like a pseudo polyp. In this case, I would go for the same technique as you did in your course. I'm wondering about additional treatment with the snare tip. Do you do this routinely like Mike Berg did it in his study to reduce the recurrence rate?
Yeah, I personally do this. It was not done in this case, but I personally do this either with APC or with a snare tip.
Mm-hmm. And for the follow-up for the question, is necessary to resect or just to take biopsies or APC? What is?
I think it is necessary to take biopsies, and the reason why we resected with a snare is that we were really unsure, and that we thought that perhaps this could be an adenoma. Therefore, we did a small snare resection. Mm-hmm. But definitely, you always need to take histology. I think no matter what you think about the lesion, even if you see a clear scar. And APC was the reason for APC was that we thought maybe if there was an adenoma, was a tiny adenoma, the patient already had a colonoscopy. It was in the ascending colon, so we wanted to save the patient from having an additional colonoscopy right away in case we saw an adenoma. But it was an overtreatment.
There's some other questions too regarding the FTRD. Somebody was asking why not just do ESD in that situation?
Yeah, I think that's a good question, and I think I could have asked this to the audience. There was a scar. There were repeated attempts in the past. This was a fourth recurrence. So I think this would have been a very difficult ESD.
Yeah, absolutely. I think this device is available in Europe. So I think many European experts, endoscopists, would go for FTR. In Asia, where it's not available, they do for sure ESD. In Germany, we have now a randomized trial comparing snare resection with FTR. I think it's indeed a great study to compare what is more effective, what is more the cost effectiveness, the complication rate, and. So I think a very important study. Okay.
Somebody was asking about, would you have potentially injected steroids after removal of the stent in the clonic stenosis? Would that have potentially have helped?
That's another, possibility, of course, to treat stenosis. But I think in this particular case, in a very old gentleman that we've, tried so many things already, then we decided not to. And I don't think that would have helped, in this very specific.
Yeah, this case was great. I mean, showed how effective we are immediately during a live procedure, but how frustrated we are sometimes in the follow-up. Very nice to show the follow-up. It's very interesting. Honestly, I also have no idea what to do in this situation.
I apologize for showing also a case that was not successful, but I think it is an honest approach and it should be also.
Yeah, maybe.
I agree.
Yeah.
We don't always succeed, so it's also important to show those types of things as well. Somebody was asking about using the Apollo Suture device. Why not just close it with regular clips? Why was that used? Yeah, what's your usual practice when you close the GPOM? I assume it's with regular through the scope clips.
Our usual practice will be regular clips, but in this particular case, we thought the opening was large and it was a good opportunity to demonstrate also this technology that can be very useful.
I mean, this patient had a perforation and Jan continued his procedure. So it was very brave, honestly, not to stop and send to the surgeon. So I think he did a surgical closure very, very nice. Okay, great. I think because of the time, we would like to continue. Thomas, thanks a lot. Were fantastic cases. And
thanks Thomas.
To your team.
I think.
Okay, let's continue, Ian.
Yeah, I think we are going to move now to Brussels.
Yes, yes.
And Jacques and Marianna. Hello, Jacques and Marianna.
Hello. Thanks for giving us this opportunity. I think it's a great concept, and we have to do it again to show the live cases with all the discussion going on in the follow-up. So we have 4 cases. I'll show the video with the 4 cases, and then I will give some voting questions and the follow-up.
Okay, great.
He's 77, but he's very fit. So that's why we're doing surveillance colonoscopy here. He's been followed up. 3 years ago, he had resection of 10 polyp or tubulus adenomas with low-grade dysplasia. She had a follow-up surveillance, which led to resection of 1 polyp. So now he's scheduled for a surveillance colonoscopy using this new artificial intelligence system, the CAT-I.
And this is an add-on system, which is only add to the system. So the idea is to do the colonoscopy, and during the withdrawal, we can change the light to go from the white light to the LCI, which is the linked color imaging.
So the LCI, it's just adding another color, so it's blue-violet color that really enhances and makes the white whiter and the colors more contrasted. And so it has been shown that it can really decrease the mist rate in the right column, which is where we really have to pay attention. Huh? So this is the blue light.
The blue light imaging. So I just have to shift. I will show you.
There we go. The virtual chromoendoscopy, where we have blue light, which really shows vascularization. It shows surface and the pit architecture to differentiate between adenomatous and hyperplastic polyps. It's better to activate the CAD when you are retrieving, after you've flushed and cleaned, and you insufflate well, and we come back very slowly and aspirate the liquids. This is the study where first there was a deep learning of the machine with more than 200,000 images of polyps. We reach extremely good accuracy levels, which are similar to expert endoscopic performances. And also that the non-experts can achieve a similar performance as the experts while using the system.
So now I have found with the LCI, you can see on the screen, and I will change to the BLI. Now you can see.
Okay.
And it's giving me the pattern that it's an hyperplastic pattern. So, and as you can see with the BLI imaging, it's clearly when you look at the surface, there is a small mucus, pit, and vessels. It's clearly an idic polyp.
The 3 bars that you see on the side, on the right side, it shows how sure it is. So here is fully sure, 3 bars.
I think it will definitely change our practice if you look at the detection rate and the accuracy of the system. So it's open a lot of questions.
Yes, to see which setting we're going to use it in. It's going to be into also a community setting, about the legal issues, who's going to be responsible if there is a misdiagnosis, if it's really can be the basis of a resect and discard system. Strategy, I think we still need some more data on the serrated polyps. So it's still a field full of possibilities for research.
Unfortunately, no adenoma so far.
We didn't found those. It's small. Okay, I will switch to the BLI mode. This is the correctly diagnosis on hyperplastic polyps.
So featureless, no vessels, and a regular surface classification.
Our first case, our second case from Brussels is 80 years old woman with a discovery at the gastroscopy 1 or 2 months ago, a large duodenal polyp in the second duodenum that you will see in a moment, situated at the genus inferius. And this patient was scheduled for a CT scan, which was normal. And so the procedure that we would like to demonstrate today is this resection of this duodenal polyp by EMR.
The lesion, as you can see, is the lower part of the second duodenum. I can show you the papilla by retrieving a little bit the scope. And this is the region here of the papilla. And so it's quite deep. You have those milky white signs all around the villi of the adenoma, which is typical for duodenoma because it's rich in chylomicrons, it's oil. And if we have some areas of the lesion which are less whitish, a bit like here, and more reddish, it might be a sign of more advanced part of the lesion, like advanced dysplasia. You can see that there is no part of the lesion that it's completely destructured. We can see the glands everywhere. And you see that my plan, okay, continue, is to start by, okay, the anal side to be sure that the lesion will not fall to the other side. You see that on the right side we have a very secure place where we see the injection, and in front of us also. So what we will do is to deploy the snare at the back. You can put the V of the snare at the tip of the catheter like that. And maybe I can just try to get here the proximal part of the adenoma. I think it's quite good. And I will suck a little bit, and you can start to close the snare. 1, 2, 3, let's go. So we see here, clearly there is still some adenoma, but we have taken the principal part of the lesion, as you can see.
It's almost en bloc, yes, Denise. We have discussed together, Arnaud and me, just before if we would apply soft coagulation in the surrounding of the margin of the lesion. I would like to show you this new device, which is called Next Powder. It's a kind of powder, but in fact, when you inject it on the bleeding side or the possible bleeding side, it starts to be a gel. We coagulate it in between the margins of the resection field, as you can see here. And I will come with the catheter, because we know that the risk after duodenal resection of delayed bleeding is between 10 to 20%. And Leila will open now the catheter to deliver the powder to be able to create this gel on the defect of which, okay, let's go, a bit more. And even at 3 days, 40% of the patients still has the gel in place. So this is really promising.
This is a 58-year-old woman. She has symptoms related to IBS since 6 years now, and already in 2005 we had detected a pancreatic cystic lesion in MRI with no mural nodules, no abnormal diffusion imaging, and no communication. So USFNA was performed with the fluid, as you see on the slide, very low CEA, no cells in cytology, negative string test. So at this point, the differential diagnosis between serous and mucinous adenoma was still undefinite. So she had follow-up at that time, because this was a 20-millimeter cyst at that time. She says still no symptoms, but the MRI shows that the cystic lesion has increased in size. And still, it's quite atypical. It could be also mucinous cystadenoma, despite the low CEA. So that's why she is scheduled today for a new AUSFNA.
This is it. So it's a big lesion. It's not very septated. There is only limited septa on the periphery of the lesion.
So we are, yes, above 40 millimeters.
Maybe you can see here some septa on the, this is quite well visible here. And also what is obvious here is that on the posterior part of the cyst, the posterior part of pancreas, there is a kind of thickening, which is irregular. And this is a bit not in favor of a serous lesion, but more of a mucinous lesion. We have here a view on a sort of calcification.
Peripheral calcification is a criteria for serous cystadenoma, but the other criteria is for mucinous cystadenoma. So we're going to do a fluid analysis.
We have the splenic artery, which is a bit in the front of the axis of the puncture, so I will have to move forward my scope and find a place where I have less chance to hurt the vessel.
And the idea is to aspirate all the fluid to empty the cyst from its fluid, right?
Yeah.
And we're going to measure in the fluid the CEA and also glucose. And if we have enough, we're going to send for pathological examination. You see the aspect of the fluid.
Yeah.
It's not at all typical of either serous cystadenoma or mucinous cystadenoma.
That's right. And you see that I'm trying to really emptying the cyst as much as possible.
So you see the idea of the string test is to test the viscosity of the liquid. It has to be more than 1 centimeter for more than 1 second. Here it's very liquid. It's like water.
So come back to the US itself. You see that the cyst is completely empty. And I will check by endoscopy if there is any bleed in the stomach, but we should see any sign of hematoma if there would be a bleeding. To my point of view, I changed a bit my ID from the beginning. I think there is a lot of evidence in favor of, at least for clinical and US picture for cystadenoma, serous cystadenoma.
We will start with a 63 years old woman who presents cholestatic jaundice in the settings of a squamous cell carcinoma of the esophagus. In fact, it's a tumor at the upper part of the esophagus. She was treated by the radio and chemotherapy and received different lines of chemotherapy, 4 different ones. And she developed an adenopathy at the level of the isthmus. As you can see on the MRI, there is a stricture at the level of the distal part of the common bile duct. And so we start already the examination performing a dilation of the structure using a gastroscope with a CRE balloon of 15 millimeter, allowing us to get through this stricture with the duodenoscope without perforation.
The position I have in front of the papilla is a little bit atypical due to the fact that we have this big tumor at the level of the isthmus of the pancreas, which means, and I think it's an interesting point, that I'm a little bit in trouble to straighten the scope, and I have a position where my papilla is a little bit too much to the right in terms of axis. And we will see with a moderate injection if we are in a structure. We are probably not so bad in terms of position of the catheter, so I found just a step, and then I will try to turn a little bit while Sonia is helping me. Perfect. Now I'm afraid you would agree that it's the pancreas, huh?
Yeah.
So that's probably a good opportunity to show you the double wire technique, because we have a difficult position. So I will leave the wire into the pancreas. I'm pushing a little bit there. I will go there. Here we have straightened a little bit the axis of the papilla. In a routine environment, I would probably have tried much longer. I think that we are in now before doing the double wire technique. But I thought that it was also an opportunity to demonstrate this double wire technique. Now you see that we are into the common bile duct. So now we are almost finished, because in such a case, this is obviously the most difficult step usually. The patient has been pre-hydrated. He has received an SID, so I will not leave a stent in place. So I will remove the wire from the pancreas now. And I'm just manipulating my endoscope with my right hand. And this is really the manipulation of the shaft of the scope, which allows to direct the sphincterotomy. I will not do a maximal sphincterotomy in this case. I will just ensure a comfortable access to the papilla. And the stent that we will decide to place in this particular case will be an uncovered stent, a 6 centimeter wall flex. Okay, you see the yellow mark, which is my landmark during the okay, here is the end of the stent. So go. So of course,
okay,
it's
fantastic.
quite quick.
Congratulations.
So before giving you the follow-up, maybe we can have the multiple choice questions. So regarding the case with the duodenal adenoma, so we saw that we demonstrated the hemostatic powder. Would you apply any preventing hemostatic powder after duodenal EMR? Yes, with clip closure, with through the scope clips, yes, with hemostatic powder, or no? So here in this case that we showed, not only put the hemostatic powder, but she also received intravenous PPIs. And she was left only with liquids the day of the procedure, and she was assessed clinically the next day, and everything was okay. Then we let her have solid food. So everybody wants a bit of security, I think, or lots of people want a bit of security. But interestingly, in the ESGE recommendation, it's case to case. But of course, it's recommended to take any preventive measures if it can decrease the incidence of bleeding. Clips cannot be a solution, but we know that sometimes if the defect is large, it's difficult to put them. It's difficult to bring the edges in, and sometimes you just traumatize the defect area. So hemostatic powder, non-contact hemostatic powder is at least an attractive solution, but we still need a bit more data on that. In this case, this patient did not bleed, but she didn't have any anticoagulation either, or antiaggregation. So the next question, so the same case, you saw my colleague Arnaud Lemers, he made a very nice optical diagnosis and showed the lesion. So how do you assess it? Is it a tubular adenoma with low-grade dysplasia, a tubulovenous adenoma with low-grade dysplasia, or tubulovenous adenoma with high-grade dysplasia? I do have the histology results to give you the answer. So what's interesting as well with the duodenal adenomas is that the optical diagnosis, the characterization with a good quality, high resolution endoscopy is very important, and it gives you a higher sensitivity than biopsies. So we recommend against doing biopsies in duodenal adenomas because it can give you, it's not very good finally for the diagnosis, but it also gives you fibrosis, makes the resection more difficult. And so here we see that, half of you were correct because it was a tubulovenous adenoma with low-grade dysplasia. The margins were free of dysplasia. And unfortunately, the patients, the Belgian patients are not as compliant as the Czech and the German patients because she didn't come back for a follow-up yet. It's supposed to be done according to the recommendations, ideally within 3 months after the index procedure. Again, not a lot of data on that, but it's there's some series that show that you already have 30% of recurrence rates at that point. But at least yearly, she has to come back for her endoscopy, so we have to recall her.
Did you perform a control endoscopy the next day?
No, because she was well, there's no bleeding, so she was discharged the next day.
Okay.
So what about your feelings on the cystic lesion? So I saw that there was a very good question in the chat about if there was a case of pancreatitis, because also pseudocyst is a possibility. No, this patient did not have any typical story of pancreatitis in her history. So would you go for a serous adenoma, a mucinous adenoma, or a pseudocyst? I have half the answer here.
Just half?
Yeah, just half. But she was discharged as well. She had no complications, didn't have any infection after the procedure. So yeah, everything goes, huh? A bit like our feeling at the end of the procedure. So we have the chemistry results. So the CEA was high, 674. So according to the thresholds, it could be, it goes for mucinous. The glucose was very low. It was less than 5, so also suggestive of mucinous. If we see during the procedure, we talked about the morphological, there was the no septa, but the wall was a bit thickened, so that was also for mucinous. And there was a peripheral calcification, which I erroneously said it was serous, suggestive for serous adenoma, but no, it's a central calcification that suggests for serous cystadenoma. A peripheral calcification suggests also for mucinous cystadenoma. So we have some criteria for mucinous cystadenoma, and the patient was operated last week. She's going well, but if we had done the webinar next Wednesday, would have had the final histology results. So I don't have those yet, but I think that the choice to operate her was correct, because we had a lot of a lot of criteria for mucinous adenoma, and the cyst was growing, and it was more than 40 millimeters. And she's a young, fit patient.
So you're putting your money on mucinous.
Yes.
Okay.
And for the follow-up,
I'm looking at questions for you.
I can also give the follow-up for the other patients. So the one with we did the colonoscopy. Of course, we didn't do any follow-up colonoscopy because now there's no more polyps visualized during the last colonoscopy. And the patient with the RCP, she did not have post-RCP acute pancreatitis. She had a double guide wire technique. She had rectal NSAIDs and hydration, but the guide wire was taken out at the end. She didn't have a prophylactic pancreatic stent, but she went well. Of course, she had a very dismayed oncological disease with already 4 lines of chemo. So unfortunately, she passed away 3 months later. She passed away in July, but she didn't have any complications with the procedure, and her jaundice was decreased.
Okay, thank you.
Okay,
Marianna.
Marianna, thank you. Thank you very much. I just want to check, Helmut, if there's a question here. I'm not sure. There's sort of a comment, but I'm not sure what they're asking.
Yeah, Marianna, maybe starting with the first case with AI. What do you think at the moment is the greatest benefit for us doing colonoscopy? Why should we use AI?
Well, I think it helps really in giving a quality threshold for all your colonoscopies, independently if it's in the morning or late in the afternoon, or if it's if the operator is tired, or so. I think it's there not to replace the endoscopist, of course, but really to have like a quality check. And I think that this is also going to evolve during time with the new data in different settings. But I think it's a fantastic tool, and that we have to use it, of course, wisely, but it's a fantastic tool.
Interesting answer, because today we had another webinar in Germany from Thomas Hucl, and my co-worker Alana Ebigbo was asked the same question, and he answered the same way as you, that the quality in total will be higher using, and not because of the small polyps we will find. So the 2 millimeter lesion is not I think the huge advantage. It's because you have the same high quality for all of your colonoscopies, I think. Yeah.
And I think that it would also give a big boost in training. I think it can be a very important training tool.
Absolutely.
I think there's the questions that are asked is also, apart from the ethical issues, also availability in every setting and also in every country, depending on the socioeconomic status. So this is all open questions.
Yeah.
I think it's going to be helpful to individual, if we're talking just about identifying polyps. I think it's going to be helpful to individuals who may be at the lower end of ADRs and will increase their ADRs. In terms of training, I think it's yet to be recognized. I'm a little bit concerned that people are going to become just completely reliant on the machine doing the work, and people are not necessarily going to learn for themselves how to identify polyps. I think there's benefits, potential benefits, but I think there's also potential risks. And I think we need to move slowly and see how things come out. The evidence will eventually show who's right and who's not right here.
Yeah, that's
okay.
Second case was great. This huge duodenal adenoma. There is no questions in the chat. I mean, we usually do a control endoscopy the next day because we have the experience that a couple of those patients have a high risk for bleeding, and depending on the lesion, we use either clipping or powder. Sometimes we do even nothing, and the next day we realize we did always the wrong. We made the wrong decision sometimes. But yeah, I think it's important to differentiate: is a papilla involved in this lesion or not?
Yes, yes.
Yeah. Do you always use a duodenoscope additionally when you have a look at the lesion, or do you think it's, if you see it like this one, it's not necessary?
But I think that's before deciding that you will treat the patient, I think you have to really know where the papilla is. So if you can identify it with the forward viewing scope, it's okay. But if you have a doubt, I think you have to use the side viewing scope.
Absolutely. Okay.
What do you do with what's your routine in terms of post polyp removal or duodenal polyps, adenomas, in terms of restarting antithrombotics?
But I think that it depends also on the indication, the clinical situation of the patient. How long can you stop them? I think you have to discuss with the cardiologist before to be sure that these patients can be restarted on. I think that 48 hours is reasonable, but this patient did not have. If she had to start on the anticoagulants or anticoagulants, maybe we have kept her a bit more, done a control endoscopy. Here, she was on the safe side. She didn't have any risk factors, so that's why. But also for aspirin, usually in high procedures we keep aspirin. But in these cases, if you can stop the aspirin, you talk with the cardiologist, you would prefer to stop the aspirin. It's probably the only procedure that you want to stop the aspirin is this kind of procedures.
Yeah.
Okay. So
I think we should go on to the next site.
Yes. Okay. So thanks again to Brussels, to Marianna.
Thanks, Marianna. Thanks to Brussels.
Thanks.
Thank you. Now we move to our last center. This center is today very busy. I saw Torsten in another meeting today. Okay, Torsten. Last but not least, the cases from Düsseldorf. Other exciting cases. How did the patients after fix? No, meanwhile, 9 months, no? Almost 9 months.
It's almost 9 months. So
yeah, let's start.
Good evening. This is Düsseldorf calling. So first 12 points from the Düsseldorf jury go to ESGE for organizing this type of meeting. So it's really an honor for us to that we have the chance to present our cases. And we are so much looking forward to the coming ESGE days, and this is a really good introduction in the coming months. So we have prepared 3 cases, and we can watch the videos. I will give a short update on the follow-up in between the cases, and then we can discuss after that. So please send in your questions via the chat function, so let us be interactive. So.
Good morning from Düsseldorf. Our first case is a 65-year-old man. In January, he received the diagnosis of an advanced non-small cell lung cancer with metastasis in the pancreatic body. Now he is under palliative systemic therapy. In March, a new subhilar mass with intrahepatic cholestasis was detected. Now Professor Neuhaus will undertake ERC to show us the endoscopic treatment of malignant hilar strictures.
This is a good indication to eliminate any risk of transmission through the endoscope by using the new disposable sterile duodenoscope from Exalt from Boston Scientific. The instrumentation part here, the handle, is much lighter, which makes the procedure more convenient, and it can be easily attached to the controller here. So it's just push the plug in to the socket of the controller, and then we can start the procedures. To enter the CBD, we bend the sphincter tome a little bit to come in this direction. Okay, now we're on the bile duct. Or maybe the cystic duct. Could do a sphincterotomy to have more space. But on the other hand, I don't want to cut into the cystic duct. So we change then to an angulated wire. Okay. Okay, we already We are already now in the right hepatic duct. So, and now we can split the wire again and show here what we do. So we split the wire. This is now the jack wire. Inject a little bit contrast, a little bit, to see if we are in the anterior lobe, which is dilated. Yes, this is the anterior lobe. So as I said, I lock the wire here. So the wire is locked. And now I pull the sphincterotome back until we see the cutting wire here. It's only 1/3 of the cutting wire inside. And now we are ready. I use the ERBI Vio 300D. So we set it to endocut I, effect 2, cutting duration 2, cutting interval 2. So I don't touch the catheter. And then I direct it towards 11 or 12 o'clock, bending. So in case we place 2 metal stents, I would like to have a little bit more space here. Okay, that's enough. I switch to use the Spyglass DS. So, and as you can see on the image, we see the Exalt, good position of the Spyglass and the Spyglass image. And I could identify the cystic duct and also the hepatic confluence. And as you can see, under direct visualization, I cannulated segment 3 of the left side. And now the next step is that I will remove SPY DS. I will insert a wire again to the right anterior lobe. Then we dilate the stricture, and then I implant a wall flex uncovered 10 centimeter to the left, 8 centimeter to the right, with a diameter of 8 and 10 millimeters respectively. So as I said, we dilated the stricture to the left and to the right hepatic duct. And you see, even by using a balloon to 8 millimeter, the hurricane balloon, we still have a small waist in the left side, but we could fully open the stricture to the right anterior lobe. So we are in an excellent position. And you also see that there is no remaining contrast. So we use the sterile instruments, Exalt as well as SPY DS. And now I'm going to release the second stent. We are nearly finished, so I pull, and Schwester Ute, yes, we are now beyond the point of no return. So I have to pull, to pull, to pull. Okay, so, and as you can see, we prefer this technique.
So yes, so this was obviously a successful procedure in this patient for the palliative drainage of a malignant hilar stricture. And so this was the follow-up up to December 2021. So after the procedure with implantation of these 2 uncovered metal stents that should, according to the ESGE guideline, be the drainage therapy of choice in these situations, there was a persistent regression of jaundice. So no further biliary intervention was needed. And the patient is still in a very good condition and undergoes systemic chemotherapy using the systemic chemotherapy. So nowadays we have also additional methods for treating these kind of lesions. We can discuss maybe later the indication for intraluminal tumortherapy, and we can discuss this later. So I would like to switch to the next case now. So this is
our next case is a 59-year-old man. In the course of an EGD, a suspicious flat focal lesion in the middle section of the esophagus was incidentally found. The histology showed a squamous cell carcinoma G2. EUS and CT scan proved a T1 N0 M0 stadium. Dr. Beyna will now undertake an ESD.
I'm now going to show you the lesion. So we are in the middle of the esophagus, and I'm now using an Olympus system, the GIF 190 HQ gastroscope, together with the new EVIS X1 processor. It's obviously a relatively flat lesion. It's located here in the 6 o'clock position, and it can easily be delineated and easily be seen in the normal white light. So I will now switch to the novel texture and color enhancement mode that comes together with the EVIS X1 processor, which makes the structure of the lesion and the vessels even more visible. So if you want to look at the vessels, it's always a good idea to additionally switch to the bright NBI mode. And if we watch the lesion, it's a very flat lesion. You can see the microvessel structure. So we don't see any nodular lesions here. This one was caused, I think, by the previous EOS investigation. So I think this is not a nodule. And if we watch the IPCLs here, it's only some elongated IPCLs, and there's no sign of submucosal invasion here, I think. And so this is a very good candidate for endoscopic resection. In these kind of tumors, the critical thing is to perform en bloc resection. And if you could achieve en bloc resection using EMR, this could be an option. However, this lesion, I think, is too large to be sure to achieve an en bloc EMR. So I would always prefer to use ESD technique. So in this situation, I now set the markers close to the lesion, but I will now do ESD outside the markers. And we have the hybrid knife I-type. I will do a very short cut to cut the mucosa, and then I'm going to inject through the tip of the knife. And now you can nicely see the lifting of the submucosa here.
So I'm not sure what happened, but the video stopped right now, and there was a poll question. So maybe we can restart the video.
We will now open.
Okay.
It was relatively easy to delineate using TXI and NBI mode. So I set the markers not using Lugauss staining, because this sometimes makes the subsequent ESD more difficult. However, Lugauss staining is a very good idea. Yeah. In this situation, I prefer to cut the distal margin first to have a clear distal margin, and then I switch to the proximal margin. So I will now start at the oral margin. Again, a short cut. Then you can see the excellent lifting. And if we now switch to the near focus mode, you can go close to the mucosal surface. And as you can see, we've almost finished the procedure. However, I would like to show you the final parts of the procedure. So we managed to go below the lesion, and we injected below the lesion. We didn't find any suspicious areas for deep submucosal invasion, what was anticipated. So we are now below the lesion, and I switch now to the near focus mode. That is helpful if you perform ESD using this short type cap, and then you can improve your image. As you can see, I have the knife close to the tip of the endoscope, and I'm now using, because we have a very stable position here, the novel dissection mode from the ERBI Bio 3 generator. I use the precise sect mode. I inject below the lesion, and the precise sect mode provides a very good preparation capability combined with the capability of performing hemostasis as well. So as you can see, we have now a vessel inside this small stalk, and what I use is still the precise sect mode. I can use it for coagulation as well. I don't use the tip of the knife, but I go alongside the vessel, increase the contact area of the knife to the vessel itself, and then I activate precise sect for a second. And so you can see the vessel is coagulated and cut at the same time. However, in this patient who is at a little bit higher risk of delayed bleeding, we will have a look at the resection site and then decide whether we will go for some topic form of hemostasis. We have prepared the next powder from Medtronic because we know this is a powder that will develop into a gel when it comes into contact with the.
So obviously the video stopped now, but this is, I think it was the end of the video. So this is okay. So this was then the final histopathology. So we were right in the indication for this ESD. So one of the most important parts of the procedure, despite from the technique, is the indication. So to identify the patients that are good candidates for resection, and obviously we were right. So this was only an M1 mucosal infiltration. So G1 differentiation, no lymphovascular, no venous invasion, and A0 resection. So this was a nice result of this tumor. And we can then go one slide further. Yeah, so this are the images of the 3-month follow-up. So very clean scar, no evidence of residual neoplasia. However, it's not only the local recurrence, but we have to also screen the entire esophagus during the follow-up period to rule out other locations of other squamous cell neoplasia. So then we can directly go to the third case.
Our next patient is 65 years old and has an LSBE, initially C1M3. In July last year, he got an ESD of an adenocarcinoma PT1A. The follow-up EGD in October showed no further focal lesions, but still remaining Barrett mucosa C0M1 with no dysplasia. Professor Neuhaus will now undertake a cryoablation and will show us this technique.
So I'm using the Fuji EG 760 CT, the therapeutic gastroscope with a 3.8 millimeter working channel, so a therapeutic scope, providing a high resolution image, as you can see. And when you now switch to the endoscopic image, you can already see the scar here on the right side at 3 o'clock. After previous ESD, which had been a A0 resection. But the concept is, of course, now to ablate the remaining Barrett, either with RFA, but here we do it with cryoablation. So this is a C0M1, and what you can see is that I already put some coagulation markers at the Z line, because as we all know, it's very important to ablate the Z-line to minimize the risk of recurrences. And with this nice endoscope, I can now switch to LCI just to give you the impression. There are not only the tongues, but also some islands of Barrett's. And I already set some coagulation markers around the islands, as you can see here. And I can switch to now BLI, which LCI is more for detection of lesion and BLI for characterization. This is the controller here with a LED display with a touch screen, so we can, for example, variate the time for cryoablation, but this is set to 8 seconds per ablation. This is the cartridge containing the cryogen with this nitrous oxide. The next step is I advance the balloon forward, as shown here. This is the balloon. This is a low pressure balloon, highly compliant, which nicely accommodates to the esophageal wall. So I press the button. Yes. So now we look through the balloon, and you see in the center the markers on the channel containing the diffuser. So, and now with this foot switch, I can change the position of the diffuser in the axial direction, as you can see. Now it comes upwards. So there is the diffuser now in the center of the image. And this is up, this is down, and pressing this button, I can now change it in the radial direction. As you can see now, the markers on the shaft are rotating counterclockwise and clockwise. And when we are in the correct position, then I push the blue pedal to activate the cryogen delivery for 8 seconds. We see the markers at the Z line. And now I apply the first spray. So you see, this is 2 square centimeters. Okay, 8 seconds. And now I rotate. You see the rotation now of the markers. So the diffuser should be now a short test. A little bit more. So I can target it very precisely, as you can see. 8 seconds. Rotation again. Short test, a little bit more. So this is ice and frozen Barrett. Okay, and now the last one at 2 o'clock. Okay, so we achieved a circumferential nice ablation of the Z line. So I deflate the balloon for a second to show you the result. So excellent result. Oh, yeah, it disappears, as you can see, but we see the slightly bluish color here. We expect a eradication rate of 90%.
Yeah, so obviously we have another option in treating our Barrett's after doing focal resection. So I'm not sure if the frozen Barrett will be an alternative to frozen Margarita in summer, but so we will have more data on the cryoablation for Barrett's. So we are close to complete enrollment in the European multi-center prospective trial, and then we will have more data on this in the course of the patient in 3-month follow-up. So we did a second cryoablation because of some residual small tongues. And then after 7 months, so the second follow-up, there was a complete remission of the Barrett's. This was not only endoscopically, but also proven in biopsies taken from the neo-Z line and also from the neosquamous epithelium to rule out buried glands in this area, because we're doing this in a study setting. So obviously this patient had also a good clinical outcome. So I prepared no questions for the audience, but I would love to answer your questions if you send them in the chat function.
Yeah, thank you, Torsten.
Thanks, Torsten.
We have questions for sure.
Go ahead, Helmut.
Torsten, let's start with your first case. There was a question about the cholangioscopy, the risk. What are the main complications and risk doing a cholangioscopy? What should the patients know about this procedure?
Yeah, that's a really good question. So we know that cholangioscopy is nowadays more or less indicated in the first ESCP approach to hilar strictures, because we know when we don't perform it in the first line approach, then we will have some artificial alterations to the surface, and this will then disturb our observation of the surface, and that what we have to see when we want to have a visual diagnosis of malignancy, for example. So we should do this in first line, but we are still really in a diagnostic and also therapeutic dilemma, because on the one hand, if we have potential surgical candidates in so ERCP and drainage, what is needed after cholangioscopy, I think, will worsen surgical outcomes. And in the palliative situation, we can perform cholangioscopy, but so we have to drain then, and we have to think about what we can do to the patient. We have the risk of infection. So this is why we should have a strategy first. So we should start with MRCP as a roadmap to avoid unnecessary ossification of the ducts, and then go with a clear strategy, what areas we have to drain. So obviously, cholangioscopy is a high-risk procedure for cholangitis. It is also very well evaluated in the ESGE guideline on ESCP-associated adverse events. So we should do prophylactic antibiotics, and then we should also drain all segments that we opacify, and especially in the setting of a cholangioscopy, this is really necessary, because we have we have to irrigate, and this will translocate bacteria upstream of the strictures. And we still have to discuss, so we have a sterilized single-use cholangioscope. We did this procedure with a sterilized single-use duodenoscope. So this is also the discussion, if we need to use disposable duodenoscopes for these kind of patients.
Yeah, I think this is still under discussion, and ESGE is publishing a statement on green endoscopy. So I think we need for sure more trials, more studies on this topic to find out which patients are really of benefit for a single-use duodenoscope. But obviously also complex procedures like this one is possible with the single-use endoscopes. I mean, this was a cholangioscopy. You placed 2 metal stents, and I think this is one of the most difficult procedures in ERCP, and Horst did a great job.
Yes, but this is also still under evaluation, because we have some data on the EXALT Model D. We have one prospective trial with 70 patients around this from the United States, then one randomized trial from Orlando that showed that the conversion rate to conventional duodenoscope was only 3%, but still there was only 80% low grade of complexity procedures. So we currently finished enrollment in an international multi-center trial with around 1,000 patients. So maybe we can get more data about the true efficacy. So from my standpoint, it's hard to believe, but the single-use scopes work very well.
Okay.
Torsten, there's a couple of questions regarding the last case, the cryoablation. One, somebody's asking, just in general, is ablation indicated for non-dysplastic Barrett's? That's the first question.
It's a clear no.
Okay, clear no. That's easy. And the second question is there any difference between RFA, cryo, hybrid APC in terms of post-therapeutic pain?
Yeah, this is the best question. Unfortunately, I cannot totally answer, because this is one of the endpoints of our trial that we are going to answer in the European multi-center trial. So the expectation is that we have a lower stricture rate and less post-procedural pain compared to RFA in the cryo group. But yeah, so I have no data, but so the results, as far as I can see, are quite well. So in the beginning, there were some issues with the catheter, but they are now completely solved. So as you can see, this was a smooth procedure with a good result of ablation. We will have circumferential. So this was a focal device. We will now have 180 degree treatment, and then also circumferential treatment. So this will even speed up the procedure, but we still have no data. And we have the third option, the hybrid APC. So the European prospective multi-center trial has been published some days ago in the American journal. And that also showed that hybrid APC is also a good option to treat dysplastic Barrett's. We never treat non-dysplastic Barrett's. However, it also depends on the individual risk of the patient, how we do the surveillance strategy, and but if we don't have any proven at least low-grade dysplasia, we don't do any treatment.
I mean, it's even also recommended in the ESGE guidelines not to treat non-dysplastic Barrett. You showed in your cryo case that after the end of the procedure, you see almost nothing, no? Compared to RFA. Did you ever check the next day?
Yes, so it does not really look nice the next day.
We did it also the next day because we saw also no effect and was wondering, is this working? The next day it looks horrible, no? Yeah, so the effect comes later so to freeze a Barrett is different to grill a Barrett, yeah? We see the effect later.
But if you wait for some minutes, you will see some bluish changes, more blue purple, and then you can be sure that you did a good job. But obviously after removing the balloon, the ice was melting.
Yeah.
So no frozen Barretts anymore.
Yeah, and your second case on squamous cell cancer, I think this was a nice indication. We had in the first presentation from Sigi a nice Barrett case where we discussed about EMR or ESD, and from Düsseldorf we have this randomized trial. But I think for squamous cell cancer, it's almost clear. There is no doubt that this is treatment of choice. Would you agree?
Yes, for sure. So it's also in Barrett's cases, it's also pre-selection of the patients, but in this case, on blood resection is mandatory, and this cannot be achieved with EMR in this case. And there's no question. And using technique that is available nowadays, so ESD in these kind of lesions is also not so challenging that it cannot be done in a safe and proper way.
Okay, thank you, Torsten. And we are almost at the end. What do you say? A bit over time. You are. We cannot hear you.
Sorry about that. Yes, we are almost out of time, but I think this was actually a really very good initial model for these live endoscopy webinars. And really, most of the audience has stayed with us throughout, even though we've run over. This has been great.
Yeah, I mean, I enjoyed really that we had a longer follow-up, what happened after half a year or so to our patients. Yep. Usually we don't have this results so late. So thanks to all participants, to the centers, to Marianna, Thomas, Sigi, and Jacques, and also Horst, who is not here. But great job. Thank you for your support and with this kind of new webinars. And I think you wanna give some last words to our participants.
First of all, I want to thank everybody for joining the webinar. I want to thank all of our experts for being here. I just want to remind the audience that ESGE Days is going to be in Prague, where Thomas is located right now, at the end of April in 2022. Abstracts actually were due yesterday. However, if you're an ESGE member, we've extended the deadline for abstract submission for another week, so you can still get your abstracts in up to December 14th. ESGE Days will be in Prague, but it's going to be a hybrid event, so there will also be live streaming. And there's more information. It's now open for registration, so you can go to the ESGE website or the ESGE Days website. And we have great faculty, great sessions lined up. I think we're really looking forward to this. I'm sure everybody's looking forward to having a live in-person event. If you're not a member of ESGE, we all strongly recommend that you do join, enjoy the many benefits of ESGE. And you should ask your home society if you have the dual membership agreement, because if you do, it's actually significantly less expensive to join ESGE, and you still get all of the many benefits, including getting the journal Endoscopy, which is the highest impact factor endoscopy journal right now. You also get discounts on ESGE Days. I feel like I'm a salesman right now instead of a gastroenterologist. But I do recommend joining ESGE. And Helmut, this is the last webinar for 2021.
Exactly.
So I want to wish everybody happy holidays and a happy new year. And the next webinar will actually be on Wednesday, January. Doesn't say the date, actually. It'll be Wednesday in January. I think it's the first or the second week in January. And it's going to be about bariatric and metabolic endoscopy with a great panel. And I hope everyone has a great holiday season. Will join us again next month for the next Wednesday webinar. And I want to thank the governing board, and I want to thank the technical team for doing this tonight.
Yeah, also from my side, thanks to everybody, thanks to those who supported us this year, and we're really looking forward for next year to meet more members. The ESGE webinars are for sure growing, and we have 2 other new projects among the webinars. So the paper of the month is one, and also some live endoscopy video sessions. So it's worth to have each Wednesday in the month booked for ESGE Days. And we are really looking forward to see you all next year in Prague. Thomas will also be very busy together with Guido Costamagna, and I think we have an experienced faculty, Thomas, in Prague, who can support your team. But it is hybrids for those who will not be able to travel, which we don't hope. But anyway, we have a hybrid meeting, so we are flexible. And I wish you also now a Merry Christmas, Happy New Year, and stay healthy, and see you soon. Latest next webinar. Good evening. Bye-bye.
Bye-bye. Thanks to everybody.
Thanks.
Thank you very much.
Bye-bye.